Welcome back to Bright Life Science Uganda, a medical channel that is dedicated to provide you with medical information, some medical lectures and revision. This video is about diabetes, and specifically this one is about diabetes type 1. And I think if some of you have been to the wards, you've been able to see that most of the medical ward, internal medicine, you see that if it's not HIV or hypertension, heart failure, it has to be diabetes. So it is quite a common condition, and in our setting here is actually globally the cases are increasing every other day, and it's really a very important topic to look at. And now diabetes as a whole is a group of metabolic disorders characterized by chronic hyperglycemia resulting from defect in insulin secretion, insulin action, or both. So we all know that when you eat carbohydrates, or you have any carbohydrates ingested, they have to be digested, and then we know that the final product is glucose, which is a monosaccharide. And this glucose is absorbed into bloodstream and has to end up into cells. So what actually happens in diabetes is that this glucose will actually not be able to leave the blood to actually be used by the cells. And we all know that there is a hormone called insulin, and it is that hormone that enables this glucose to leave the blood to enter the cells. So in this condition, which is called diabetes mellitus, there is a problem. So that insulin is either not produced, or it is produced but it's not working as expected. So it is either not produced, that is what we call type 1 diabetes, or it is there but it is not being used. In fact, we say there is insulin resistance, which is type 2 diabetes. Now, diabetes mellitus type 1 is also known as juvenile onset diabetes mellitus, simply because it is mainly diagnosed during childhood, and we see that the onset is always during childhood, though it can also be diagnosed during adulthood, and also we see that it can happen at any age. So the science behind this is that there is autoimmune destruction of beta cells of the pancreas. What you need to know that these beta cells of the pancreas are the cells that are responsible for the production of insulin. So when these cells are destroyed, that means there will not be any insulin that is produced, and therefore we're going to have our presentation as we're going to see in type 1 diabetes. So the etiology, we want to see what causes this actually. The most acceptable etiology is the autoimmune destruction of the pancreas, the pancreatic beta cells, which is driven by both the genetic and environmental factors. So most individuals are actually genetically predisposed, as there are some genes that are involved in the pathophysiology of this condition. But also we have some environmental conditions that kind of contribute to this happening. So genetically, the genetic bit of it is kind of complex, and we see that there are multiple genes involved, and also we see that there is a high sibling relative risk. So if you have a first degree relative that has had diabetes type 1, there are chances that you're also most likely to get it. And I think you guys are very conversant with what first degree relative means. Is that immediate relative, like your mother, your father, or even your brother and sister. So that one tries to tell you that there is a genetic component attached to diabetes type 1. But also we have the environmental factors. Like for example, the viral infections like enterovirus, mumps, rubella, and Coxsackie viruses before. What happens actually here is that when that virus infects your body, the body or the immune system is going to act by producing antibodies. And these antibodies that are produced to act on this virus will also attack and destroy the beta cells as well. So these viral infections can also predispose someone to having diabetes type 1. Then also we have the toxic chemical exposure. There are some chemicals that can lead to destruction of the beta cells. Then early exposure to cow's milk in infancy and some cytotoxins. Pathophysiology. The hallmark here is beta cell destruction. Actually, there is going to be lymphocytes infiltrating the pancreas, leading to the destruction of the insulin secreting beta cells of the islets of Langerhans. And actually, as we know, that since these are the cells that are producing insulin, when they're destroyed, there's not going to be any insulin. So hyperglycemia starts to develop after almost 80 to 90% of the beta cells have been destroyed. So the pathophysiology is just as simple as has been stated. There is an autoimmune destruction of these beta cells. When they are destroyed, no insulin production, and therefore there is going to be hyperglycemia, simply because it is the insulin that is meant to drive that glucose from the blood to the cells. So when there is no insulin, glucose accumulates in the blood, hence giving hyperglycemia. And also what you need to know here is that there is always at least an autoimmune trigger, as we've said already, that we can have viral infections that can stimulate production of antibodies that are going to destroy the beta cells also. You need to know that the most common isolate cell antibodies target GAD. What I'm trying to say that this is an enzyme that is found within the pancreatic beta cells, and it is an enzyme that is most commonly attacked by these antibodies that are fighting the beta cells or that are destroying the beta cells. Now here we can see that the series of progression of this condition, you're going to start by genetic susceptibility. So there's going to be genetic predisposition, and when you're genetically predisposed, now environmental factors come in. So from genetic predisposition, you're either going to have viral or any other environmental trigger, and that is going to lead the autoimmune antibody response, which leads to the beta cell destruction, hence leading to failure of insulin production, and that gives you hyperglycemia. The epidemiology, we see that over 8.4 million people are living with type 1 diabetes worldwide. This is quite old, it was 2021, and 50% of the new cases are diagnosed after 20 years. So however much we say this is juvenile onset diabetes mellitus, we see that almost half, in fact half of the cases are diagnosed after 20 years of age. And also that it is more common in males. Yes, it is typically diagnosed in childhood, adolescence, or even early adulthood. Yes, I need to know that this type 1 diabetes mellitus is associated with a high morbidity and premature mortality. Now, diabetes has consequences, the complications, and all these are resulting from the inability of the glucose to move from blood to the cells. So the cells are going to be left starving as the glucose accumulates in blood. So we're going to have hyperglycemia, but at the same time, the cells that are meant to use this glucose are starving. So we have the acute complications and the chronic complications, and we're going to start with acute. And the number one complication in acute is the diabetic ketoacidosis. Now, what actually happens here is that there is going to be accumulation of ketone bodies simply because when glucose is not entering the cells, they'll try finding other ways of surviving. And cells do this by breaking down lipids. So even also the absence of insulin kind of activates some hormone called the lipase, which breaks down lipids to free fatty acids, which are later going to go to the liver and are going to undergo beta oxidation from these ketones. So actually there's going to be ketones or ketone bodies accumulating in the blood, and that's what causes the acidosis. Then also have the hypoglycemia. Hypoglycemia, mainly this one is a complication of management. As we give these patients insulin, we kind of tend to overdo it and end up having hypoglycemia. Then you also have smaller hyperglycemic state. This one is a result of hyperglycemia. So the blood here is going to be a bit thick, and we'll see this in details. Then another complication is infections. Yes, these patients are going to be more prone to infections, as we'll see that there are some microvascular abnormalities, some wound healing issues, and also there is going to be some bit of impairment in the immune system, which kind of increases the risk of these patients acquiring infections. Now, chronic complications, we have the macrovascular and then the microvascular. The microvascular, we have the diabetic nephropathy, diabetic retinopathy, and then the diabetic neuropathy. Then the macrovascular, we have complications like coronary artery disease, for example, the angina pectoris. You can have myocardial infection, myocardial infarction, and heart failure. Then you also have cerebrovascular disease, for example, stroke and TIA, transient ischemic attack, and then peripheral arterial disease. So as we continue to look at the complications, we need to know how these complications come about. Now there are two hallmarks here, the neuropathies and then the angiopathy. So to start with, we need to know that the angiopathies are mainly due to the microvessel involvement. So there is going to be what we call a hyaline arteriosclerosis, and this is the thickening of the small arterial or capillary walls. So the hyperglycemia, or the too much glucose in blood, is going to lead to the changes in the walls of the blood vessels, the small blood vessels, the arterioles and the capillaries, and it actually makes them very thick. And this causes ischemia, and in fact it's going to cause ischemic changes in the kidney, the retina, the brain, and then the peripheral nerves. So when it causes ischemic changes in the kidney, that's when you're going to have the diabetic nephropathy. In the retina, that's when you have the diabetic retinopathy. And then the brain, we're going to see some other presentations. And then also the peripheral nerves. This one contributes to the neuropathies, as we're going to see. Then also, still under the angiopathies or the blood vessel pathologies, we have what we call the atherosclerosis of the main renal arteries, and this also contributes to the diabetic nephropathy and can cause chronic nephron ischemia. Now the neuropathies, we have the sensory and autonomic, and these are due to the axonal degeneration and segmental demyelination from the accumulation of sorbitol in the peripheral sensory nerves due to sustained hyperglycemia. So when there is hyperglycemia, we have some of the metabolites of glucose, like for example sorbitol, and this sorbitol is responsible for the axonal degeneration and segmental demyelination. And when you have these two, you're going to end up having neuropathies, and these individuals are going to have issues with their sensory and autonomic systems. So they also have what we call the motor neuropathy and the cranial mononeuropathy, which results from the vascular disease in the blood vessels supplying the nerves. As I said earlier, that since the blood vessels are being affected, and we also know that the nerves also receive blood supply, so when they are not receiving adequate supply of blood, they're also going to have issues. Other complications include diabetic foot, eye disease, poor wound healing, sexual dysfunction. Diabetic foot is due to both the neuropathies and the angiopathies, whereby the angiopathies are going to lead to ischemia, as we saw, and the ischemia is going to later lead to necrosis. Then the neuropathies means that this patient is not going to be able to feel in case there is any injury to the foot. Yes, that predisposes to more and more issues. So eye disease, like cataract and glaucoma. Then also you're going to see that these patients are also going to have blurred vision. And then poor wound healing, still due to the angiopathies, there is limited blood supply to the feet or to the periphery. So that means there is not going to be enough white blood cells reaching the site of injury, so leading to poor wound healing. And then sexual dysfunction. Also, we need to look at how these patients present, so the clinical presentations. So we have our classic triad. The three P's are polyuria, polydipsia, and polyphagia. Polyuria means you're going to pass out excessive urine, and this is due to the excessive glucose or the hyperglycemia in blood. And that means as this blood is going through the kidneys are also going to excrete excessive glucose. And now, given that the glucose is osmotically active, it's going to move along with water, and that means you're going to have excessive fluid being excreted or urine being produced. Then given that you're passing out a lot of fluid, you're going to be dehydrated, and that means the thirst centers are going to be activated, and that is what is going to lead to the polydipsia, and therefore you're going to take in a lot of water. Then also have what you call the polyphagia. Polyphagia simply refers to the excessive eating, and this is due to the fact that the cells are not receiving glucose. That means that the cells are starving. And now, given that the cells are starving, how much the glucose is there in the blood, but it's not reaching the cells, it means there's going to be a sensation of hunger, and therefore this patient will constantly need to eat. These patients will also present with lassitude, nausea, and blurred vision. As we said, blurred vision is due to the hyperglycemia. Now, you need to know that the hyperglycemia is going to cause hyperosmolar states, and the hyperosmolar states will affect the lens and the vitreous humor. So glucose and its metabolites will cause osmotic swelling of the lens, and this is going to distort the focal length. And of course, when the focal length is distorted, that means you're going to have issues with vision. That's why these patients are going to end up with blurred vision. Then you also have fatigue and weakness. Still same reason, the cells are not receiving glucose, so there's no any source of energy, so you're going to have fatigue and weakness. Then some other thing to note here is that we've seen all these symptoms and signs. Yeah, we know that these are the signs that are going to happen in these patients, but now when do they present? We're saying that the presentation or the onset of these symptoms is actually sudden. Yes, it's actually sudden. So these patients actually may have their first presentation as the DKA, the Diabetic Ketoacidosis. Someone is coming in the DKA, and that's the only first thing you're going to see that will tell you that this patient is actually diabetic. Now, also have other GI symptoms. Yeah, for example, nausea, seen there. Then abdominal discomfort, pain. And as we are looking at DKA in details, you will see that these are some of the presentations. Then you can also have the right upper quadrant pain. That this can be due to the acute fatty liver, and which will cause the distension of the hepatic capsule. Now, on examination, the findings will depend on how the patient is presenting. Yes, if the patient is presenting with DKA as their first presentation, they are going to present with Kussmaul respiration. Then signs of dehydration, they may be hypotensive, and then in some cases, these patients are going to have altered mental status. Now, routinely, when you're dealing with these patients, the diabetic patients, there are things we actually need to be doing quite often. For example, monitoring the vital signs. We need to do the fundoscopy examination. Of course, you know why we're doing this, because of the retinopathies and the eye issues. Then we need to limit the vesicular and neurologic examinations, but also we need to do the foot examination. Yes, because we know that these patients are prone to having the diabetic foot. Now we're looking at some conditions that represent like Diabetes Mellitus, the differential diagnosis. Yeah, we're starting with endocrine disorders like endocrine tumors that produce some hormones. For example, growth hormone, glucocorticoids like cortisol, glucagon, catecholamines, and somatostatin. So we need to know that these hormones are responsible for increasing glucose in blood. For reasons like growth hormone, we know glucose has to be there in blood so that can be taken up by the cells for them to divide. Then cortisol and catecholamines, those are stress hormones, and we know that during stress, of course, you need the energy. Yes, also the glucagon, we know that what that one does, and then somatostatin. Then another differential, there are drugs like diuretics, the thiazide diuretics, the phenytoin, glucocorticoids again, and then also have what we call the diabetic glycosuria and the renal glycosuria. We also have peripheral neuropathies from alcohol abuse or vitamin B12 deficiency. Yes, we know that one of the presentations of diabetes is the neuropathies. Yes, loss of sensations, tingling sensations. But this could also mean something else like vitamin B12 deficiency or even alcohol neuropathies. Then I also have another differential here, lead nephropathy. Yes, we saw that we have diabetic nephropathy, so we can also have lead nephropathy that may present like the diabetic type. Then also type 2 diabetes. In fact, type 2 and type 1 diabetes almost have the same presentations. It's only the etiologies and some bit of management that a bit differ. Yes, now diagnosis, we have our diagnostic criteria here, whereby we can do the random blood glucose, fasting blood glucose, HbA1c, that is the glycated hemoglobin, and then the oral glucose tolerance test. So the cutoff values here, as you can see, if you're to do random blood glucose, it has to be above 11.1 millimoles per liter, the same as 200 milligrams per deciliter. But this one, if you use it to diagnose diabetes, there has to be signs and symptoms also. So if a patient is to be diagnosed of having diabetes using random blood sugar, it has to be on top of having those symptoms like polyuria, polydipsia, unexplained weight loss, and even polyphagia. Then you can also use the fasting blood glucose, which the cutoff is if it is above or equal to 7 millimoles per liter. Yes, and we're trying to say that fasting actually means that having 8 or more hours of no caloric intake. Then HbA1c is the glycated hemoglobin, whereby when you have excessive glucose in blood, it's going to be kind of combined with some hemoglobin, and that's what we call the glycated hemoglobin. So this can also be used in diagnosis of diabetes mellitus, and we're saying that if it is more than or equal to 6.5%, yeah, that one points to diagnosis of diabetes mellitus. And also the oral glucose tolerance test, the OGTT. This one, we give this patient 75 grams of glucose orally, and then we wait for 2 hours. And then after those 2 hours, we're going to measure the blood glucose, and if it is above or equal to 11.1 millimoles per liter, that one can also point to diagnosis of diabetes mellitus. Now we have other laboratory investigations. What we can do, we can test for fructosamine levels, and this one can give a hint on how the glucose levels are in blood. Then you can also do the white blood cell count. This one is mainly done to rule out infections. So we can also in fact use the urine cultures. Then there are some other tests we can do to differentiate between type 1 and type 2. Yes, for example, the C-peptide. Yeah, we need to know that during the synthesis of insulin, there is some other core component that is produced with insulin, and that is the C-peptide, which is always produced in almost equal amounts like the insulin. So if you have low C-peptide, that means you also have low insulin. So a value of less than 200 pmoles per liter supports type 1 diabetes. Then you can also test for the isolate autoantibodies, the anti-GAD antibodies. Remember, we said that GAD is one of the enzymes that is mostly affected by these antibodies. So we can actually also test or look at these autoantibodies during our diagnosis of type 1 diabetes mellitus. Management. Now, as we're looking at management, we should not forget that our main problem in this condition is insulin absence. So there is no insulin. So as we're managing these patients, that's the main goal. We want to make sure that we replace the insulin so that the glucose can be moved from the blood to the cells.
Yes, and now the principles of care, we have three, and as we are seeing, the number one is the lifelong insulin therapy. Yes, as I've just said that we need to replace that insulin. Then you also need to know that this is going to be a multidisciplinary approach whereby you're going to involve as many as possible healthcare providers, make sure that the health of this patient is taken care of well. Then also we have a target, a glycemic target, and we're saying that HbA1c should be kept below 7. Now this one is a bit higher number compared the cutoff we used in diagnosis, because in diagnosis we said it should be above 6.5%, but here in management we are saying we aim at reducing the HbA1c to less than 7%. So this is on purpose, whereby we're avoiding a very low value that could actually lead us to hypoglycemia. Yes. In diagnosis, we said HbA1c of more than 6.5%, but as we're managing, we're saying an HbA1c of less than 7%. Yes, and I'm saying that we are maintaining a bit higher value so that we avoid complications like hypoglycemia. Now, insulin therapy is the number one goal in treating these patients, so we need to replace the insulin that is missing in their bodies. So insulin has types. Yes, insulin has types. We have the types depending on the onset, when it actually starts working, and then the duration, how long does it stay when it has been given to this patient. Now we have the injections. Mostly we use the subcutaneous injections, but we also see that we have the inhalational formulation, as we're going to see, the freezer. And also we need to know that insulin, we have the natural insulin, which is actually just recombinants of the human insulin. And then also we have the artificial, what you call the animal insulin. So insulin that is given these patients can either be gotten from humans, but also you can use the animal insulins. Yes, for example, pigs and some other animals. Now, depending on the duration and time of onset, we have the ultra short acting insulin. For example, the Lispro, aspartame, glycine. Then also we have the rapid acting, or what we call the short acting. For example, regular insulin. Then you also have what you call the intermediate. For example, the NPH, the neutral protamine hagidon, or the Lent. Then you also have the long acting insulin. For example, glargine and detimine. And I've said we also have the freezer, which is an inhalational formulation. Now when you look at this graph here, the graph is also trying to show you the same thing, different types of insulin depending on the duration and time of onset. Now the long acting, you can clearly see that for it, the onset, it takes some good time before it starts working or before it reaches its peak, but it actually stays for a very long time. Compare these other types like the intermediate in green, the short duration, the in orange, that is, and then also we have the ultra short acting in blue. Now, after knowing that, when you're giving this insulin, we give it in different formulations. We have the insulin regimens, which describe how insulin is actually going to be given to our patients. And our first insulin regimen we're going to look at is the Basal-bolus regimen. Now, before you even look at this Basal-bolus regimen, you need to know what actually happens in a normal individual. Now, normally, insulin is produced. There is a basal value or a basal amount of insulin that is produced constantly in the human body. So there is always that insulin that is constantly being produced that maintains the basal glucose levels of blood. But remember that in the course of the day, this individual is going to have meals. Now, every time this person eats or every time this person gets a meal, there's going to be a spike or a sudden increase in the glucose of blood. So that's what we call a glucose spike. And every time there is that spike, there is going to be a corresponding increase or a spike in insulin secretion that is going to be released to make sure that 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 sudden increase in glucose is brought back to normal. So that's what actually happens in a normal individual. There is a baseline glucose that's being maintained by baseline insulin that is produced constantly, but every time this individual eats food, the spike in glucose is brought down by a corresponding increase or spike in insulin levels. Now, when you're looking at basal-bolus regimen, that one kind of tries to mimic what actually happens in a normal individual. So in basal-bolus regimen, what we try to do is to give insulin in two forms. We're going to give the basal insulin, and that is going to be a long-acting type of insulin that is given at a given time. Times we give it at around bedtime, and we give it to maintain the basal glucose levels. And we also give what we call the bolus. Now boluses, these are pre-meal insulin formulations which correspond to the spikes. So every time someone is going to eat or to have a meal, they're supposed to take another insulin injection. So what we do here is that we give a basal, which is going to maintain the basal glucose, and then every time this person is going to eat, we also give another pre-meal or post-meal insulin injection, what we call the bolus. So you can either give it pre or immediately after the meal, depending on the type you're giving. If you're giving it pre-meal, if it is an ultra short acting, that one you can give like around 0 to 15 minutes, around 15 minutes before the meal, or immediately after the meal. If it is short acting or rapidly acting, not ultra short acting, that one you can give like 30 minutes before the meal or immediately after the meal. And we're seeing that the dose here, the dose is 0.3 to 0.5 units per kg. And we need to know that when you're giving the basal-bolus regimen, remember we're using two types of insulin. The basal, which is long-acting, and then the bolus, which is ultra-short acting. Now, after calculating the total dose, let's for example, we say we're using 0.5 units per kg, and you calculate and then you get your total insulin. You're going to make sure that, let me use like for example, if you got 12 units, you make sure that the 6 units are long-acting, and then the other 6 units are the ultra-short acting. Now this long-acting, you give it during bedtime. At bedtime there, it's going to stay for a very long time. Now every time this patient is going to eat, that's when you're going to give your bolus regimen, which is the ultra-short acting. Now this one is going to be divided into the number of times this individual is going to have meals. But we tend to make it a universal thing, whereby we assume that individuals or people have 3 meals a day, and we say we have breakfast, lunch, and supper. So we're going to divide this 50% of the total insulin, and depending on our example, we say it is the 6 units, into 3. So we're going to have a pre-breakfast, pre-lunch, and a pre-supper. Yes, so just before breakfast, someone is going to take another injection, then just before lunch, another injection, and then pre-supper, like that. Yes, and this type of regimen is very good at maintaining or regulating the glucose levels in blood. Yes, because it is very close. It kind of mimics what actually happens in a normal individual. But it also has some disadvantages, like for example, you see that the patient is going to receive an injection for the long-acting and 3 other injections for the boluses. You see that this patient is going to have like very many injections in a single day. So that can affect compliance because it's kind of hectic and causes pain to the patient. Also, given that you're giving insulin several times during a day, if this patient happens not to have eaten well, or if this patient engages in some exercises that are kind of vigorous, they may end up having hypoglycemia as a side effect, because like you're giving insulin several times, but they're not taking in enough, or they are using it at a very fast rate.
Now we have another type of insulin regimen called the mixed regimen, and here we combine types of insulin, whereby you're going to have a rapidly acting insulin being combined with an intermediate acting insulin, here for example NPH, and what we get is just divided into two doses. So we give two injections, one in the morning and the other in the evening, after combining the two. Now how do we calculate? Now we get our total insulin by using a dose of 0.3 to 0.4 units per kg, and after getting that total we use the 70-30 rule, whereby you're going to get 70% of that total as your intermediate and then 30% as the rapidly acting. Yes, so for example, your total was like 10 units. You're going to make sure that the 7 units are the NPH, the intermediate type, and then the 3 units of the rapidly acting insulin. So you combine them, you mix them, and after mixing them, you divide them into two, whereby you're going to give one in the morning and the other one in the evening. Now you make sure that after combining them, 2/3 of that is what you give in the morning, and then 1/3 is what you give in the evening. So 2/3 is given before breakfast, and then in the evening you give the 1/3. Now this type of regimen has some advantage, whereby that the patient is going to be receiving fewer number of injections. We're seeing there are only 2, so that one can improve compliance. But and also there is a low risk of hypoglycemia, because it looks like we're giving a bit lower amount of insulin. But the disadvantage here is that it's not as effective as the basal-bolus regimen in keeping the glucose levels in check. So it's not as effective in maintaining the glucose levels as close to normal as possible. Then there is another type of regimen called the sliding scale. Now this one is not very different from the rest, only that here we measure or we check the blood glucose several times during a day. Yeah, so here we're going to give every time the patient is going to have a meal. The only difference here is that we don't have any fixed dose we give. So the dose here depends on the amount of glucose that has been measured at that particular time. So we are saying that the dose of insulin we're going to give in this case can either slide up or slide down, depending on the glucose levels in blood at that particular time. And this one is especially used in the admitted or hospitalized patients. And if you look at this table here, if you measure and you find that your glucose is between 161 to 150 milligrams per deciliter, there you don't give any insulin. Then if it is between 151 to 200, you give only 3 units. Then 201 to 250, you give 5 units. 251 to 300, you give 8 units. 301 to 350, you give 10 units. And then 12 units for 351 to 400. So if it is above 400 milligrams per deciliter, there you give 15 units. But you need to note here that if it is above 400 milligrams per deciliter, you must inform a physician, and they should actually intervene. So I was trying to show you that a value of more than 400 milligrams per deciliter requires more specialized attention.
Other management measures, these are the other things we're going to do for these patients on top of the insulin therapy. Yeah, they include monitoring the glucose frequently. Yes, we're doing this to make sure that our patients don't undergo hypoglycemia, but at the same time they're not hyperglycemic. Yes, it can also be used to monitor the treatment, if our medications are actually working as expected. Then we also need to manage the complications like DKA, HHS, infections, and also the diabetic foot. Then another thing here is that we have another treatment modality, which is the artificial pancreas. Yes, that one can be made. And then another thing we need to do is to look at their diet. Yes, these diabetic patients, they need some kind of special diet, whereby we may have to limit the carbohydrates. So we include the vegetables, water, then also regular physical activity. We need to know that activity is part of good health, and every time you exercise, there are glucose transporters in the muscles. They also help in the uptake of glucose from blood to the cells. And then patient education, actually this one is very important. These diabetic patients need adequate education. They first of all need to be educated about their condition. They need to know it very well. And then they also need to be educated about the medications most patients will see that they may have to be giving the injection to themselves. They also need to how the injections are given, where, when. They also need to be taught on how to detect for the side effects. Like for example, we talked about the hypoglycemia. These patients need to be taught how to detect, like for example, the tremors, the sweating. These patients needs to be taught what should be done in case of the hypoglycemia. Yes, and other things that patients need to know, the complications of the disease. So they need to know how to detect them and what to do in case they come across such. And then another treatment modality here is that they can do pancreatic transplantation and cell therapy. Yes, then as we're using our insulin, there are some reactions, allergic reactions, as we've said. As I said that we have the recombinant insulin, which is human, and also the insulin that is gotten from animals. Now that insulin that is from animals, it tends times to give us some allergic reactions, but also even the recombinant insulin can give you reactions. Now the reactions are divided into two. We have the general reactions, which are kind of rare, and also the local reactions. Now for the general reactions, these ones can actually occur immediately after the injection, and they include urticaria, angioedema, pruritus, bronchospasms, and also they can give circulatory shock, but that is rare. Now, when you have such reactions that are general, you can treat them using antihistamines, as we do for any other type of allergic reactions. But also, if it is severe enough, you can also resort to giving epinephrine or IV steroids. Then for the local allergic reactions, these are the most common, more common compared to the general ones. They are local because they are going to actually happen at the site of injection. For example, pain, burning sensations, local erythema, pruritus, and then induration or a swelling at the site. Now these ones, they usually resolve spontaneously without any intervention. You can intervene in case it is very severe, but in most cases they resolve without any intervention. And then these patients, as they are giving their insulin to their body, they also see that there's another complication here, what we're calling the fat atrophy or hypertrophy. Yes, this one is a complication of insulin. We know that insulin as a hormone has some effects on fat metabolism. As we said, that it has effects on the lipase enzyme. So actually, as these patients are injecting insulin to their bodies, there are going to be some local reactions at the sites of injection, whereby there's going to be either atrophy or hypertrophy. So you can have the lipoatrophy of insulin injection. Now what actually usually causes this is the injection being put at the same site. Yes, you can see those images there. They're trying to show you the lipoatrophy at the repeated injection sites. So we deal with this by encouraging our patients to to inject the insulin in a rotational manner. So they kind of try to rotate the injection sites, not injecting at the same site every time they are giving themselves the insulin. Or you can also advise the patients, or as the medics, we try to switch to a different insulin preparation.